Good morning, everyone. My name is Sherry Triff. I'm a dental hygienist and a dental therapist. On behalf of the association, I'd like to welcome you to the 2022 Minnesota Dental Therapy Association Conference and Celebration of 10 plus 1 years of dental therapy in Minnesota. And I want to thank you all for coming. I want to thank you, the speakers who graciously are speaking today. We have a full day, so just remember to enjoy yourself and meet other people and meet old friends. Just to note, the bathrooms are down the hall and to the left. And also we have sponsors in the back. Make sure to sign up for prizes. We have many prizes to give away. We have a pair of loops from Surgitel to give away. And then we have drink tickets for later on. And that's from Michigan Public Health Association. Elevate Oral Care is one of our sponsors, and they are designated as a approved PACE program provider by the Academy of General Dentistry. So that's really nice of Elevate. Thank you. All right. Well, we are extremely honored today to have Dr. COLLEEN BRICKLE as our keynote speaker. COLLEEN is the Dean of Health Sciences at Normandale Community College. She graduated from the University of Minnesota in 1976 and completed her master's degree in curriculum and instructional design in 1988. Colleen's been a real advocate for dental therapy, and we're so happy that she's here today. If you want to give her a warm welcome.
It's an honor and a privilege to be here today. Thank you, Sherry, and thank you to the Minnesota Dental Therapy Association Board. And thank you to all of you for coming today. This is pretty historic. I'm going to begin the day and set the stage, but the other speakers are going to offer so much to really show you how we can celebrate our collective impact of dental therapy and advanced dental therapy in Minnesota and beyond. Are there people Zooming in too, Sherry? I didn't know or not. Or is it just, okay, perfect. I didn't know for sure if we had people from the outside and I was going to greet them. Okay. So this is my disclosure. Neither I nor members of my immediate family have any financial interests to disclose relating to the contents of this presentation. So, I think of the many hours, sometimes I wish there were some financial gains, but there wasn't any. It was very much out of passion and the heart. So really quickly, I'm just going to talk about past, present, and future, really collective impact, really a brief overview of dental therapy in Minnesota. It's my brief overview, but I was in the thick of it, and I can tell you sometimes I hear things and I really think, no, it isn't exactly how it went. But I don't have time for a lot. Presence, really success in sustaining a new workforce model. And then I really want to talk about education here, our high standards and voices of dental therapists and advanced dental therapists. And then I'm following with the future. What are opportunities and what are the benefits and what's on the horizon? So in 10 years, we'll be back to see if this really comes to fruition. Okay, so the past. I'm going to start there. And as I was preparing this, I was telling the table, it's really hard for me. I have so much information swirling around in my head to sit down and really just hit the highlights today in a 45-minute presentation. But I think what I really need to tell you that, so many people thought, oh, it went so fast in Minnesota. The 2 legislation sessions in 2008 and 9, yes, they did. But there was so much work before that. And that's the past. And I really do think it was a perfect storm during those 2 years and a convergence of a lot of alignment of forces and dedicated people, many that are in this room, that had a lot of passion to really do something for the underserved in Minnesota. So, all right, so I'm going to start here. So Minnesota first. As I was doing this, and Heather and Kelly heard me say this before at another one, I really looked at Minnesota first, like we were the first of good stapler and masking tapes and Post-its. Who can live without Post-its? And then we have Wheaties and green giant vegetables and the bunt pan. And we have Bisquick, And then we have the snowblower. And we know we're going to need that snowblower. We actually beat Canada out for the snowblower. And then exercise, roller blades, and the Nordic track and water skis. I mean, we truly are kind of a well-rounded in every season state. But for me, really, for healthcare, first I wanted to put the heart here. We were the first to do open heart surgery, the first to have the blood pump in 1955. We did the implantable pacemaker. We did the first pancreatic, kidney, and bone marrow transplants. That's pretty amazing here in Minnesota. This is another fact, and I love this one. We were the first state to mandate dental continuing education. It was passed in statute in 1969 and became rules in 1971. And I have to shout out for Mary Jo Keyworth, who was it was her husband who did that, and she used to teach at Normandale. So good for Bruce. And then the last thing I think that's really important is minute clinics. They used to be called Quick MedX when they first started, and they originated here. And then when the health insurers finally accepted and approved the ideas, they took off. And I do think this could be an area in 10 years we may need to watch for dental therapy. But most important, in 2009, we were the first state to government in the United States to authorize licensure of dental therapists and certification of advanced dental therapists. The first license was Kelly Myers, and the first certified advanced dental therapist was Christy Jo Fogarty. So they're in the room today, so good, hats off to them. Okay, so I think a little bit more. So what about the past? I put access to care. This could be huge, but for many of us, I think it really launched the century when the Surgeon Generals put their reports out. The first one was Surgeon David Satcher, General Satcher. I met him, David, and I'm not going to tell the story, but I'm saving it for my book. But all I'm going to say is that, you know, he really, the silent epidemic he brought to light, he really brought to light the disparities of oral health, especially among certain races and social economic groups. And then the second national call to action by Surgeon General Richard Carbona. I remember he came to a national oral health conference, and that was really fun. And he really enhanced the awareness that we really need to do something with the oral health workforce. And that's huge. So, so in 2000 to 2003, full disclosure, I am a dental hygienist, but they worked really hard at the ADHA level looking at this. And at their House of Delegates in 2001, they already passed look at what they were calling the advanced dental hygiene practitioner. In 2004, it passed, and they started a work group. In 2004, too, very important, New Zealand there were Alaskans that went to New Zealand in 2003 and came back in 2004 to begin practicing. And this was an interesting conversation earlier, but they really talk about some real pioneers that came back and they paved the way. But we know access to care is critical, and we know why we did it here. You know, the safety net clinics, we had long waiting lines, we had a shortage of dentists, emergency room. Maybe it's more a maldistribution, but we had it. So a real quick thing, in October of 2005, I was sitting in a room in Normandale, and we had a Minnesota Dental Hygiene Educators meeting, and Kathy Leonard Griffin turned to me, I'm just off the ADHP. I think you should do it here, Colleen. You do it, and I'll help you. I thought, okay. All right. So I went to my dean. This is really the truth. And she said, okay, well, let's go to the U, but you have a sabbatical next year, so maybe you could start working on it. So December 5th of that year, we went over to Metropolitan State and met with all the DPs and the president, and sort of that was the beginning of a great partnership. And then my sabbatical, I went on. That'll be in the book. Okay. So Minnesota Change Agents. You might not know these people, but my goodness, they were really what I would say from Senator Clinton, gutsy women. They were brave, they were pioneers, all four of them. Dr. Marilyn Lowen, nurse practitioner, Dr. Kate Manahan, nurse public health nurse. She was my dean. They really inspired leadership. They had shared vision, they were innovative, and they were willing to change. And then the other two, Dr. James Cernahouse and Dr. Suzanne Beatty. Dr. Suzanne Beatty and I have been friends since 1976. they really had worked with dental hygiene students, they'd worked with dental students, but they loved the foundation of a dental hygienist. For example, local anesthesia, what they saw you dental hygienists go through from what they had, they thought, whoa, this is the foundation we want to start on. They felt a master's because they wanted to follow the model of nurse practitioners and physician assistants, and that was really important for Marilyn and Kate. It's very successful in medicine. And we all felt at the time this would be a standard that if we were going to move this forward, that we thought Minnesota could embrace due to the history of things I just told you. I mean, we believe in higher and high standards. So that's where that led. So then the new program application, one of the things I had to do was form an advisory committee in 2006. And this was the advisory committee. I'm not going to go through all their names, but look at them. They are two. They not only helped with the program development curriculum, and we were working on things. We were in a dental school. We were looking at things. We looked at the ADHP competencies. We looked at competencies for the new general dentist. We looked at CODA standards for dental students. We did everything. And really, some taught in the program, Dr. Amundsen, Dr. Kinnenberg, Dr. Taryn, and of course, Dr. Beatty and Dr. Cernahouse. But we really looked at things and we were dedicated. And then they ended up later on being advocates more at the Capitol. They did everything. Some continued after 2010, but this group worked so hard, and I can't thank them enough. And you need to know that and recognize that. Okay, so why dental hygiene-based dental therapy from this perspective back then? As I just told you, I'm a hygienist, and the people I worked with kind of knew. So here's a little graphic. It's the best thing I can do. I'm not real creative like Dr. Helgeson, but you look at the foundation of a dental hygienist in the middle. They really know dental caries. They know oral pathology, health promotion, and disease prevention. They know non-surgical. And so when they were developing, we thought starting with that foundation would give them a solid lead. But then look at this. In the dental therapy and advanced dental therapy, we do not have, in the scope of practice here, periodontal. You learn more going through your master's. You increase definitely your knowledge on dental caries, more on oral pathology, what's normal, abnormal, and then health promotion, disease prevention. But truly, periodontal disease is the other. And why did they too? I'm going to give a shout out to Dr. Julie Sater from Australia, because we are dear friends, and she said, you've got to go with it. New Zealand and Australia at the time were just adding adults, and they said we're combining them and calling them an oral health therapist because both diseases are so important, and we're finding that out. So going on the wisdom of her in New Zealand and even Great Britain was another reason we went that route. Maybe we were ahead of our times, but that's why we went with it. I think what's also really important, I'll go here. I wanted to do these three main groups. I'm not going to go into it a lot, but really this was collective impact. This is a case study. And I just, there was a common agenda. There was data out there. We coordinated organizations. You guys, once I counted over 8,000 emails I had in that 2-year period from 3 different groups. With the Safety Net group, it was really the Oral Health Committee, and at the time, Sharon Oswald worked for the United Way, and she funded that. Then we had the Minnesota System, formerly MinSCU. I can't tell you enough how they stepped forward and were champions. And then, of course, the Minnesota Dental Hygienists Association. So very important groups. Again, I can't put everybody's name on here, but these are really, really key people. And as you see, a little caveat plus. So those in the room, there's many of you were. But, Representative Saitow and Senator Ann Lynch at the time, man, you need your champions. But the advocates were also champions. And they brought this forward. So, you think about the groundswell of 59 organizations were gathered by these groups. And they had, listening sessions, called legislators, had handouts. It was just unbelievable what they did. And they had their lobbyists helping. And they testified. Most of the people that were on the advisory committee of dentists testified. So it was very, very important. So a little background, too. Why did we do this in Minnesota? And I think it's important to expand, establish, and provide. But mainly we wanted to expand the dental workforce. We really wanted to be able to reach different target populations. We wanted to establish a new intraprofessional licensed member, someone who would be educated and trained to the same standards as dentists, were within a specific scope of practice. Specific scope of practice. And then provide really primary care. And I think out to underserved areas, that's where the advanced really does extend the reach. and they can get out and really bring the care to patients and communities. I think what's really important, this really is a social justice at the time. It wasn't just access to care, it was really a social justice issue. Because when you do collective impact, it really has to be solving a social problem. As I mentioned before, I look at the dental hygienists took over 20 years to do local anesthesia because they were the only ones doing it. Once you have groundswell and have other partners, look what can happen. Okay, so trying to move it. Okay, so again, briefly, before we move on, name changes, so you know why we started with an advanced dental hygiene practitioner. At the end of the legislative session in 2008, we called it an oral health care practitioner, which was fine. And we had a work group, and I can't tell you, there were so many topics. We talked about lots of issues. I'm not going to go through it. We're pretty intense meetings, but we looked at things like populations to be served and scope of practice and supervision. And we looked at education. We looked at assessment and evaluation. And we looked at accreditation. And in the end, we had a report that was to go to the legislature. No, we didn't get consensus, but we did get good compromises by the majority. And it really defined what the issues would be. The issues going into 2009 were scope of practice, supervision, and who was going to educate. Plain and simple. In the end, at the end of 2009, to reach those compromises, we ended up with 2 levels, a basic dental therapist and an advanced dental therapist. And again, a lot of work went into that, and at the time, behind the scenes, there were students starting, especially at the time it was the Metropolitan State Normandale Community College Joint Program, and they were underway. So what I want to say here, and these are the only 2 pictures I could get. I got a different one, Metropolitan State graduates, because I always get slammed for the one I always choose. They, talk about trailblazers, talk about pioneers, talk about people starting, and the legislation passed on May 16th, and they had started on like May 9th. And then the University of Minnesota, too, they graduated a couple months following Metropolitan State Normandale. So this is pretty important, what they did and what they accomplished. So hats off, and please, why don't you stand up if you were in that class, or at least wave so people can, in that first cohort. There's many more here. Yes, we need to recognize them. Thank you, thank you. Okay, so there you go. That's what sort of passed. I'm going to quit there. Oh, you're doing pretty good, Rhonda. All right, so now we're into the present. And I think the presence, again, I thought, okay, well, did we meet our goal? I think we did. We're filling a gap. We're getting dental access to vulnerable populations. The ADT is really extending beyond the borders of the office and really hitting our other patients that can't get in. I think that we know dentists are vital to the model that we always said. And so are the other dental team members, you guys, the dental hygienist, the licensed dental assistant, and the community health worker, navigator that's going to be part of it. They're all important, but we're doing it. And today, from Bridget, I know there's 132 dental therapists licensed, and there's 98 advanced dental therapists. So pretty great. I think we're on our way present. But I think, too, we have to remember, I'm going back to this for a second. This was based on public health. That's why in the law it said limited practice locations. It says to work primarily for low income, underserved, or in a health professional shortage area. And remember, it's not the practice that has to meet that 50% threshold, it's the practitioner. So it really opens up a lot for an office to really at least try to serve some of that community if they haven't in the past. And I always have to say that. That's what it came about. That was the social justice. That's why those groups fought for it. And I think we need to upheld that as long as we can. But the core principles of public health are assessment, policy making, and assurance, and we sure did that. But then in the middle are the 10 essentials that started in about 1994 when they were really looking at healthcare reform. And if you put any activity can fall into these categories, whether you do them all or together. But look at the middle as research. Research is critical. And system management. System change. We took steps with the dental therapist, but we still need to continue our collective impact. because we need a system change, and we need you as an organization to step up with the other dental groups and really make this happen. And I just have to put that out there. It's really much broader than just dental therapy, but it's an important element. So dental therapy educational guidelines. I think it's really important too that the law, in the end, it had to be board approved. And I think this was important. I think the language put in there was very important because Michael Scandrett was wise in saying CODA approved or another accrediting body or meeting, of course, board approval so that you could practice and get licensed. And I think that's very critical. But a couple things. This is in law that the basic level is a baccalaureate and in advance a master's degree. The other thing that's in law does not dictate to educational institutions what their admission requirement is or how to structure their program. This was really important for at least Minnesota State at the time, and especially if they wanted to do advanced standing and career laddering. And the other was different educational institutions establish different types of programs as long as they appropriate educate and train students to the level of competency that's necessary. And I think that's really important. The Board of Dentistry really, we need to give them, they stood up after, the board passed, the legislature passed in 2009. They had 4 committees, licensure, credentialing, policy. They had their allied committee and professional development. I think I spent more time there in that 2 years than ever. The real work really began after the law passed for both the Board of Dentistry and all the educational institutions. Yes, you had it, but this was based on something you hadn't tested yet. So anyway, I think this is really important, and they did the right steps, the Board of Dentistry. Okay, so next, these are the 3 institutions that are now conferring dental therapy degrees in Minnesota. And I have to say again, it's really, really important that we really support any of these, no matter where you graduated. It's hard. We know that there's a new administrations coming in and budgets and outcomes. This is a very fragile part of our infrastructure. I'm going to shout this out more than anything. Higher ed is more, I've been at Normandale 35, I've been in higher ed even longer. It has really changed since the pandemic, and I think there's going to be a lot of major changes and programs being cut and changes happening. And we need to be a force again. We need to have our collective impact and really to help the citizens of Minnesota. It's very important. These are our 3 program directors right now. I think, is Dr. Petta ready? Did she make it in? I know Andy Jordan's here in the back, and I know that Dr. Self had some other commitments. But again, you should really be gracious. They're working hard, new battles, and they really need our support, especially with accreditation issues, especially CODA. Something in the future, for another day, we need to talk about. Here's something I did on my own, and it isn't, it's something I thought. I worked with somebody on this map. So I looked at the collaborative management agreements with Bridget Anderson, and I just took zip codes. Zip codes don't say a lot exactly. That's one dentist and where that collaborative management agreement was submitted. But if you really look at it, I made it, where are there more than 1, 2, 3 to 5, and 5 plus? And they are scattered. We are predominantly probably still in the Twin Cities, but that myth out there that nobody's practicing any place but the Twin Cities. And we do have health professional shortage areas in the Twin Cities, and we do have the most population. So this looks pretty good if you really look at it. We have to work a couple on that northwest corner a little bit and that northeast corner, but it's coming. But then I thought, I'm going to call 2 of the biggest safety nets, Apple Tree Dental and Children's Dental Services. And again, I just ask them zip codes. So sometimes a zip code, they might have 10 to 12 places in one, St. Paul or Minneapolis 20. But I just, again, wanted to show you where they are, that they are expanding in other areas if we didn't have advanced to really go beyond the bricks and mortars and really expand it. And I think that is critical. Got to remember to push this towards me. Okay, so then I thought I better show this better because I know what I'm talking about. Look at these 2 maps now. So what do you see? I think what you really see, and by the way, you know, Apple Tree has like 8 permanent spots. Children soon to have 3. But that's why you saw more red dots. But look at the counties that weren't covered. Coochiching is covered now. We have Becker, Wilkins, Grant, and Pope over here by Ottertail. We have Meeker, closer to the Twin Cities. Then look around the Twin Cities. Look what's reached beyond. Atkins, Mille Lacs, Kennebec, Pine, Sherburne, Isanti, Chisago. Pretty amazing. And then look at the southwest corner, which was really struggling. I can remember some of the legislators down there. But anyway, now we have Pipestone, Rock, Nobles, Jackson, and Cottonwood, beyond. So it's pretty incredible. So we do need to look at this a little differently, and different ways to look at distribution for legislators to really see how our safety net. They have a great system, you guys. It isn't different than the pay mile, but it needs to be looked at. Okay, quickly now I want to do this. So Rhonda helped me, and thank you. By the way, raise your hand. Some of the dental, did you fill the survey out? It was just some quick questions, and it wasn't anything scientific, but thank you. We hadn't done it in a while since the Department of Health, you know, they had planned a new survey, and then the pandemic hit. So I just wanted to ask some questions, and I can't give you everything, but I'll have to type it all out. But I think the first question, or 2 questions into it, there was some demographics. Just after 10 plus years, how have dental therapists and advanced dental therapists been received by patients and communities? Well, this by both groups. This is what I got. I mean, everything. I just put it doesn't show up as well, but well received, well respected, grateful, pleased, positive, greater access. It just went on, and the stories, and they put narrative down, and it's fabulous information from, you know, my community role has been received. We are bringing economic growth and benefit to our community. Patients they're thrilled to be able to get care quicker. Opening access. It just goes on, and they're so well received. So thank you to all of you out there. This is exactly what we were hoping. It was overwhelmed. The other question is, after 10 plus years of graduates with working well. And again, many things I had to look for themes, but I'm not going to read them because of time, but it's really that flexibility and giving care. It's that public health came through, you guys, and that's what this profession was for. And meeting the goals and understanding just of the full dental team. And look at these. I think they're just great. You're providing even dental hygiene services for the ones that could to restorative. So it's gained a lot for everyone. The other thing really quick, and I have a lot more to share later, but after 10 plus years, are you aware of challenges or obstacles? You know, biggest thing, I know prescription's been out there, and a few, of course, they want more with their exam, or the problems of changing a treatment plan and then having to get that changed. That's a challenge. The direct billing, maybe additional locations for referral in rural was one of them. And then also unable to speak. They couldn't get loan forgiveness is a problem, time management, and some other limitations by some dentists and not allowing them to do their full scope. But nothing really major. Things that we can't conquer. This question I put in there is too much education. I used to hear this all the time. And yet, and there's a lot behind this, but I just wanted to know. And 96, it is master's degree is needed. 2 people actually said it should be higher. There were 2 that have their bachelor's and are doing great with it, and I think that's good because we do have that in law, and they now found a pathway to advance. But I think they basically, again, it's the nurse practitioner and their colleagues and being comparable. At least a dozen, they're being accepted more in communities because of that, and they feel they're part of the team. So I think that's really important. So, good job. And what advantages if somebody is dual? And again, don't have a lot of time, but the advantages, you can see the production, flexibility, chair time, versatile employee. They can increase access in more than just the dental therapy scope. And then for patients, again, many are the same, but it saves them time, 1 practitioner, which is really nice to follow through care for the majority of care they need, and greater access, sort of same themes. But again, kind of fun to see what our dental therapists and our advanced dental therapists are saying. And then what advice, this was a great question, this leads us into the future, would you give somebody? And I like this too, and again, oh my goodness, I was just giggling some of it, but do it, go for it, absolutely pursue it. It's rewarding. You know, shadow though, I saw that, read that at least 6 times. Shadow and see what it is. Have a passion for public health. Learn about what populations you're serving is really important. Um, uh, you know, be willing to advocate. And you're a new profession. You really got to step out and work for yourselves. I put the last one because it kind of leads into the future. We won't spend time, but I do think quota is a barrier, and a couple people said it. So they were saying maybe you should wait. But we got to overcome that obstacle. We aren't having complaints at the Board of Dentistry. We have very competent graduates here in Minnesota, and we've got to figure this out. So that's leading to the future. So here we are in the future. Okay. So, again, I think besides CODA, I just did a couple things. You know, the healthcare system is changing if we don't get breaks. And I think right now we really need to see what's going to happen at the state and federal level. But we really do know they need to put more resources in it. Healthcare systems need to help us to make system change. We're going to need to expand, like the medicine, the nurse practitioner, physician assistants, maybe collaborative dental hygiene practice. Love to see you guys get behind that group. Advanced dental therapists, we need to do that. And then integration of oral health into primary care, very, very important. I put this up here. I found this, and recently I'm doing something on interprofessional education at Normandale. Very few community colleges are doing it, and I want them to be kind of, to be a benchmark. But anyway, one of the things I learned, we had the triple aim in 2003, and that, you know, we wanted improved patient experience, outcomes, lower costs. Well, it happened, but then they started to do a little more research into it, and they realized for the quadruple aim in 2014, we better include the clinician, because research showed that if you have decreased clinician engagement and burnout, you're going to have lower patient satisfaction. You're not going to have good outcomes, and the costs are not going to be they're going to be higher costs. So then, lo and behold, now we're at 2021. We've added another layer, health equity, which has always been there as part of it. But I think we really, you know, the social determinants of health drive about 70% of healthcare costs. So we really need to address it, because if we do take that into conclusion, we're going to meet our improved patient care outcomes and costs. So just something that I think in 10 years it will be fun to see where we're at. It's going to improve our economy overall. Okay. This just came out. I think some of you heard about it. I just have to say there's a lot Community Catalyst. Hi, Mark. They did a little presentation. I'm going to say something. Dr. Helgeson and Deb Jacoby wrote to get me on this committee, and I was just, as of last week, put on it for next year. And it is the Advisory Committee on Training in Primary Care Medicine and Dentistry. And that's the acronym. There's 17 people on it. I'm the only dental hygienist, but I'm there to represent dental hygiene, dental therapy, and dental assisting. That was my pitch. And I will, because they're all important. But I got to speak to this group along with Valerie Davidson from Alaska. And then I got to review the report ahead. I couldn't talk about it, but I was so pleased and so excited that I couldn't wait till it came out. And you need to look at it, because some of the things I was hearing, again, you gotta look at my watch, okay, they're public health. They're putting dental therapy as part, their importance. They really saw the importance of dental therapy, and they really wanted to be at the pre-doctoral and faculty development grants. It's part of it now. They also want to make sure that there's $6 million put in it annually for dental therapy program, training programs. How exciting is that? They want to put another $1 million in for number 3 for dental therapy faculty loan repayment programs. This is phenomenal. The other 2 things that are great, look at loan forgiveness and scholarship repayment. Woo, finally, we're going to get it in there. And last, really a longitudinal study to really look at the clinicians, look at population, retention of this new profession, practice locations and population served. Some of the same things we kind of had put in the state a long time ago. The other thing, too, that's happening at the federal level a lot, and this kind of helped me with Community Catalyst, but I also knew the alternative dental provider grants. We'll watch and see. You know, dental therapy has been in there but pulled out always. The language is in there. If you look at that second one, the Senate bill really gives strong reason to expand access and equity in dental care, and that takes all dental hygienists and licensed dental assistants and dental therapists. Health policy, we know we have bills, but they need to pass, and we need to watch policy, and we need to be involved. But I'm glad to see adults again, but we know, and we were just talking about it yesterday, what is medically necessary mean is that they're discussing it at the federal, we're discussing it at the state, and we really need to flush that out and figure that out. So future directions. These are some of the big topics. We actually, I think back to when Dr. Sonnerhaus Beatty and Dr. Manahan alone, we talked about a lot of these things already when we were thinking about the program, and we still need, now we know aging population. We know the nursing home is going to double. We know populations there. Case management, we need more on that. Safety net role, comprehensive prevention, risk-based disease management. It's common. And of course, the last two bullets really have to do with health equity. And we know it's everywhere. We're all working on it. We're all trying to prove it. So what I really see, my own out of everything, really towards access for all, that's a little symbol we have on the 21st Century Dental Team website. I really want to see outreach teams, the advanced dental therapist, a collaborative dental hygienist, a licensed dental therapist, and a community health worker, all going out and providing care. Kind of the hub and spoke that they're out there, and this will really make use of people's scope of practice and will deliver more care to more locations and expanded base. And how exciting would that be? It might even, I'm sure I'll be retired, but I want to get out of retirement and maybe do something. We might be closer to the quadruple aim. I think we will. Increased use of telehealth. Absolutely. The telehealth was in that previous slide. They're really looking at that at the federal. IPE again, too. And then team-based care. Really need it. And lessons learned, here they all are for you, Minnesota Dental Therapy Association. When you take something forward, remember all these. Stick to that goal. You know, things change. It wasn't exactly how I thought it. Standing here today and seeing you makes me really pleased. We're changing things. And you can't always get what you want, but if it's there. Your principals say, any of these, you just have to. Have it with grace. There were disappointments, but I've been on myself, I've always been on the same message. I haven't wavered, and I'm sticking to it. And you really need to do that. So I love this, very love this from the Bush Foundation. It's not about what you do. It's about the culture you create that helps other people feel a part of something big and want to work towards something bigger. That's what I'm leaving with you today. So I think it's time to celebrate our impact of collective impact. So thank you.